All right, so today we're going to be talking about preventing ototoxicity-induced hearing loss in children receiving chemotherapy. I don't have any disclosures relevant to this presentation. A third of children with cancer receive cisplatin therapy. The reported incidence of ototoxic hearing loss varies greatly from 21% all the way up to 90%. And as I discovered from many years of research in this area, this variation is due to differences in treatment, the age of the patients, as well as wide variations and inconsistencies in ototoxicity reporting criteria. Cisplatin ototoxicity typically causes bilateral, symmetric, permanent sensorineural hearing loss, although sometimes it could be asymmetrical. It appears first in the high frequencies, but can progress to low frequencies with continued treatment as well as higher cumulative dose. The time course can be variable, gradual onset, progressive and cumulative, or even sudden. And there is some evidence that hearing loss can progress years after cisplatin is discontinued. Here's a typical high-frequency sensorineural hearing loss seen 6 months after end of treatment. One of the things that may have caused less attention focused on cisplatin-induced hearing loss is that a large proportion of the hearing losses fall into the so-called minimal hearing loss categories. Minimal hearing loss has been defined by Best as bilateral hearing loss in the 15 to 30 decibel range, or isolated high-frequency loss above 3,000 hertz. However, while this has been labeled minimal hearing loss, there are indeed significant pediatric concerns. These so-called minimal hearing losses may have significant impact on developing speech and language skills. High-frequency loss means loss of high-frequency consonants, low-energy sounds that are critical to speech intelligibility. These hearing losses can also cause disproportionate difficulty in background noise. Studies have shown even normal hearing children perform poorer than adults and adolescents in noise due to limited past experience to fill in missing information. Loss of these high frequencies also results in difficulty hearing women and other children. The hearing loss may go unnoticed. The child may be unaware of their hearing loss or unable to articulate their hearing problems, and thus parents and caregivers may be unaware of the hearing loss as well. And so these so-called minimal hearing losses result in greater difficulty in the educational system than one might predict. And indeed, if you look carefully at the educational performance of children with minimal hearing loss, you can see lower performance, not just in speech, but in reading vocabulary, language mechanics, word analysis, science, and spelling. Teachers identify significant issues in these children, and the rates of failing one or more grades is 37% compared to 3% in normal hearing peers. Looking specifically at pediatric cancer population, Gurney et al. Found in 137 neuroblastoma survivors, 43% of these were reported as having hearing loss. And these survivors with hearing loss had twice the rate of parent-reported problems with reading, math, attention, language delay, and/or special education needs, as well as poorer child-reported quality of life and school functioning. So what are the risk factors for this hearing loss? Younger age is one of the primary risk factors. Children younger than 5 years of treatment can have up to 21 times the risk for hearing loss compared to adolescents. Increased cumulative cisplatin dose causes greater degrees of hearing loss. Cranial irradiation alone can cause hearing loss, often conductive and also often delayed in presentation, but in combination with cisplatin, there is a severe intensification of the ototoxic effect. The use of other ototoxins can be a major risk factor as well. Here I show some data demonstrating how combining cisplatin and carboplatin drastically increases higher grades of hearing loss. There can be a genetic risk factor as well. The most promising study of the role of genetics in cisplatin ototoxicity involved two cohorts identified through the Canadian Pharmacogenomics Network for Drug Safety. They utilized a gene chip comprised of variants in 220 drug metabolism genes and found that genetic variants of TPMT and COMT were significantly associated with cisplatin-induced hearing loss. So given what we know about these risk factors, can anything be done to prevent cisplatin ototoxicity? All of the currently well-studied protective agents fall into the antioxidant category. The theory here is that the primary mode of cisplatin hair cell damage is from the production of oxygen-free radicals, and that any agent that diminishes these free radicals will protect the outer hair cells of the cochlea. These four antioxidant agents listed here, D-methionine, N-acetylcysteine, amifostine, and sodium thiosulfate, are the most well-studied in the animal models. And in fact, I've studied N-acetylcysteine in the guinea pig model during my early years here at Stanford. Only amifostine and sodium thiosulfate, however, have been used in large human clinical trials. Amifostine primarily at St. Jude's Hospital trials, and sodium thiosulfate in the Children's Oncology Group and International Society of Pediatric Oncology multi-institutional trials. Over the years, I've had the fortune to participate in many of the studies involving these agents. And as I worked with the various collaborators in this space, it became obvious to me early on that the evaluation of the efficacy of otoprotectants in children would require multi-center cooperative clinical trials with careful audiologic measurement and standard ototoxicity criteria. So after carefully studying the defects in all of the criteria that were being used by oncologists prior to 2008, I looked at the Stanford Children's experience evaluating hearing loss in cisplatin patients and developed a new grading system to address the defects that I saw in the commonly used criteria. The resulting publication in JCO was accompanied by an editorial which called for a new consensus among pediatric oncologists in the evaluation of these patients. One of the points made in the editorial was that there were too many contradicting criteria used in the various oncology trials, making it difficult to compare ototoxicity in different studies in patients. And the editorial strongly advocated for an international standard for the evaluation of end-of-treatment audiologic results. And so a meeting was convened. This was the International Society of Pediatric Oncology that occurred in Boston in October of 2010. And there were 4 working groups that convened at this meeting. And I was asked to be co-chair of the working group assigned to come up with a consensus that audiologists and oncologists both felt comfortable using. Listed here are the members of this working group. So here are some of the considerations that our working group had to consider. Some of the grading criteria that already existed were quite ambiguous. And one of the questions was it preferable to specify change from baseline or the actual threshold? Should these guidelines be different when there's a pre-existing hearing loss? There had to be some guidelines for grading incomplete data, which is very commonplace in all of the trials, as well as guidelines for grading otoacoustic emissions, ABR, and minimal response levels. Should the grading focus on functional outcome? And should it inform clinical decision-making? And finally, do studies of otoprotectants need stricter monitoring criteria? Now, after 2 months of telephone conferences with exhaustive tabulation of current research into a working document and 2 days of deliberations at the Boston PSYOP conference, we were able to come up with a consensus, which satisfied all of the goals listed here, as well as provide specific, explicit guidelines for auditory assessment. And so the goals of this ototoxicity grading system were that it had to be sensitive to ototoxic hearing loss. It had to be applicable to results obtained in children. It had to specify severity of hearing loss at the end of treatment time point and be consistently and reliably used, clearly defined, correlate with functional outcomes, have high inter-rater reliability, offer guidelines for grading incomplete audiologic data, which we discovered was very commonplace in pediatric audiologic evaluations of young children who are uncooperative and super sick from their cancer. And then finally, accurately assess the efficacy of otoprotective agents. During these discussions, the auditory specialists on the panel all felt that the Chang grading scale that I presented previously satisfied all of these criteria. However, all of the oncologists felt strongly that the scale could only have 4 categories. And since mine had 6 categories, they did not want to use it. So this PSYOP ototoxicity grading scale was the final consensus, and this was published in JCO in 2012. Since 2012, most large clinical studies have standardized their ototoxicity assessments to either the Chang and or PSYOP grading. And actually, I would say currently, all of the current multi-institutional trials use the PSYOP grading scale. I want to now spend some time talking about the big 2 studies that really demonstrated there can be a way to prevent cisplatin-induced hearing loss in children. Penelope Brock led this multi-institutional European study coordinated by PSYOP, which was published in the New England Journal of Medicine in 2018. This was a prospective randomized controlled trial of children with hepatoblastoma. And they were randomized to receive cisplatin alone versus cisplatin plus sodium thiosulfate. This sodium thiosulfate was given IV over 15 minutes, 6 hours after completing the cisplatin infusion. Now, if you look here on the left figure, many more patients receiving sodium thiosulfate were protected from hearing loss and measured at grade 0, with greater numbers of cisplatin alone patients showing higher grades of hearing loss. And this protection was achieved without any detriment at all to either event-free survival or overall survival. And they also found no side effects to the sodium thiosulfate treatment. Now, at the same time that PSYOP was running this European trial, there was a parallel trial being run by Children's Oncology Group in the United States. And this was led by David Fryer and published in Lancet Oncology in 2017. This trial included children with newly diagnosed cancer receiving cisplatin, and they were randomized to receive sodium thiosulfate versus observation. Now, of note, this study included all tumor types. And as you can see here on this table, very few of them were hepatoblastomas. And instead, most of these tumors were either germ cell tumors, medulloblastomas, neuroblastomas, or osteosarcomas. The dose of cisplatin in these patients was much higher, 200 milligrams per meter square or more, as opposed to 80 milligrams per meter square in this previous trial. And this trial was also a lot more heterogeneous because the children in the previous trial all received the exact same dose of therapy. And in this trial, they had different cancers and widely different doses. They just had to have the requirement of more than 200. There was also a slightly lower dose of sodium thiosulfate given in this trial, 16 versus 20. And they defined ototoxicity in the trial by ASHA criteria. And as you can see here on this graph here, the observed ototoxicity was halved in the sodium thiosulfate patients. Moreover, this otoprotective effect of sodium thiosulfate was much greater in the vulnerable young patients under 5 compared to the older patients. When they measured mean changes in hearing thresholds, the protective effect was quite marked as well. But there was a big problem. At the end of the study, when they analyzed all of the combined data, they found that the sodium thiosulfate group had both decreased event-free survival as well as overall survival. And of course, this caused a lot of consternation. So in order to try to understand this alarming result, they performed an ad hoc analysis by separating out the participants with localized disease from those with metastatic disseminated disease. And once they did this, they found there were no differences in survival in the localized disease patients. You can see the graphs on top are the localized disease patients indicating event-free and overall survival. And there really was no difference. However, there was a difference in the disseminated disease patients as seen in these lower graphs. But there was one other perplexing observation. And that was that the control group in the disseminated patients had surprisingly high survival rates, not clinically expected. For example, if you compare the red lines here, C is almost the same as A, even though C represents a metastatic cancer patient and A represents a localized cancer patient. And here, the patients in D actually had slightly better survival than the patients in B. So you're saying that the metastatic cancer patients had better survival than the ones with localized disease. So these blue lines, C and in C and D, are actually what they clinically would have expected in patients with metastatic cancer. But for some unknown reason, the metastatic patients in the control arms had unexpectedly high survival rates, and they couldn't explain this. But nevertheless, this result cast a big pall in the study, and there was some confusion among pediatric oncologists whether or not it was reasonable to utilize otoprotectants in their cisplatin patients, even though both studies clearly showed very strong hearing loss preventive effects. So in 2019, over the course of 9 months and countless Zoom meetings, a group of us hashed out an evidence-based clinical practice guideline on preventing cisplatin-induced ototoxicity in children. This included a systematic review, which starting from 2092 references, identified 27 randomized control studies suitable for consideration into this CPG. This table on the right kind of summarizes the effect sizes seen in the 27 studies. And you can see here that only sodium thiosulfate had a statistically significant effect. All of these other randomized studies failed to show a statistical effect. So these were the summary recommendations of the clinical practice guideline. I grouped 1, 2, 6, and 7 here, which basically state that there was not enough evidence to support the use of other non-STS otoprotective agents to prevent cisplatin-induced hearing loss. One of these guidelines I want to call your attention to, recommendation number 6, do not use intratympanic middle ear therapy for prevention of cisplatin ototoxicity in children and adolescents with cancer. The reason for this was because the studies involving intratympanic therapy were all very, very small, and in these small studies, there were kind of answers on both sides. In fact, the largest number of studies were on N-acetylcysteine, which was the animal project that I worked on early on at Stanford. It was one of the early candidates for good intratympanic therapy. But when they tried it in humans, there were kind of studies, they were all small studies showing kind of both ways. And so at the moment, even though this was a method that some of us were excited about, we couldn't give a recommendation to support it. There just wasn't evidence. The remaining recommendations, 3 through 5, are shown here. And basically, these recommendations say that sodium thiosulfate could only be strongly recommended in children with non-metastatic hepatoblastoma and possibly considered in other non-metastatic cancers. Now, if you look at the remarks here, there's a recommendation against using sodium thiosulfate in children with metastatic cancers, but it was a weak recommendation due to what we thought was low quality data from the Fryer-Cog study. And there were many panel members that felt the jury was still out on whether or not sodium thiosulfate truly compromised survival in metastatic patients, and felt that a new randomized controlled trial focusing on this group of patients was warranted. But until that study comes out, the recommendation is against using. So while sodium thiosulfate clearly protects children from cisplatin-induced hearing loss, concerns over possible compromise on tumor treatment can forever inhibit widespread usage, even with the current clinical practice guideline. So that brings up another question. What if there's another way to administer sodium thiosulfate, i.e. not systemically? So I'm currently collaborating with Etan Orgel at the Children's Hospital LA and Jennifer Foster at Texas Children's Hospital. And we're proposing a multi-institutional COG-sponsored prospective randomized controlled trial of intratympanic sodium thiosulfate with our 3 home institutions as the initial 3 study sites. And although it is much more difficult to administer sodium thiosulfate via transtympanic approach, which in our study is going to require a brief mask inhalation anesthesia, like we do for ear tube placement, we do strongly believe that this approach does bypass oncologists' concerns about cisplatin compromise to the anti-tumor effect. And basically, based on preliminary results seen in both animal studies as well as human studies, we even think the protective effect of transtympanic sodium thiosulfate may be enhanced over IV sodium thiosulfate. So hopefully I'll be presenting data from this exciting study on a future grand rounds. I realized after I rehearsed this for the first time that it was a lot shorter than I thought, but I'm hoping that there's some questions that this presentation will stimulate, and I'm happy to stay here as long as possible to kind of talk about this topic, because I can talk about it forever. So yeah, thanks for your attention.
Thank you, Kay. I guess I have a few questions. I'll start. So do you expect the effect of STS to be even higher, since the previous studies had different doses and the patient population is quite heterogeneous as far as the cisplatin dose they got? Did they underestimate? Is there a protective effect underestimated in the previous studies, you think?
Yeah, but also the other thing that you should realize, and I think that was another problem with the COG study, the Children's Oncology Group study, is that the patients that can most benefit from this are the younger patients. In fact, I don't think that older patients can benefit that much. So it completely depends on the age group of the population that you're studying. So if you have a cancer that's all in older patients, you're not going to be able to find a really great protective effect. But if you have like neuroblastoma in all under 1 or under 2, you're going to have a massive effect. And I think that graph that I showed you of the difference that it showed on the kids under 5 versus over 5 really kind of shows that. And so this is going to be very dependent on the composition of your study group.
Got it. There's a question from Mighty. Do many children recover from cisplatin ototoxicity? Is there some of it that's reversible?
It has been found. I think probably the reason why Mighty asked that question is because actually she wrote a really good paper with me on this. We had a patient who we had really good audiologic studies on, where there was a significant high frequency hearing loss, which then improved over time. And we published this. And there are other reports of this. But in general, the recovery isn't that frequent. And so, it's not a high percentage of patients. I would say it's probably in the 1% to 2% range, which isn't clinically significant.
You see a similar effect sometimes in mice, depending on the protocol that you use. On the short protocol where you induce hearing loss, if you stop using cisplatin, you can regain some of that hearing function. So that's why we prolonged a little bit some of the exposure to assure.
Also, I think that some of this recovery thing has to do with how soon you get the audiologic study. For example, if you do an audiogram immediately after the patient's nailed with a cisplatin, like within 12 hours, you can get this really strong, big decrement in the hearing thresholds, which may be more like a temporary threshold shift that you get from noise induced, which then recovers later. So Most studies now, when they're trying to look for kind of the effect of the cisplatin, they're going to wait at least 1 or 2 weeks out at the end of therapy to get that final number. Because if you get it too soon, it may not actually represent the situation. And I think some of the previous reports in the literature about recovery are due to that issue.
Hey, is there any role for intratympanic steroids?
That's funny that you asked that. Interestingly, I actually got Stanford involved in a study with Autonomy, and Autonomy had this product, Oto 104, which was actually a product that they originally wanted to propose for the treatment of Meniere's disease. And it was an extended release gel that you placed inside the ear that would release steroids, and they thought that it would help treat Meniere's disease, but they wanted to try to use this in a cancer protocol and place this gel in the ears, but it was steroid, dexamethasone. And originally when they proposed this, all of the oncologists were like, why don't we use something that actually has been proven, like an antioxidant? Why are you using steroid? There's no real known mechanism of how steroid would improve, except that steroids improve other types of sensory motor hearing loss, which with no understood mechanism. But the reason why Autonomy did this was because they had the product. And interestingly, I got the entire thing through the Stanford IRB. We negotiated a contract with Autonomy, and we were about to start the project. And right when we were about to enroll our very first patient, Autonomy canceled the project because their trial of using the Oto 104 for Meniere's disease failed, and they had to withdraw the product from the market for Meniere's. And because they had to withdraw from Meniere's, they decided they weren't interested in this anymore. And so they had this thing started at all these different centers, and then they just withdrew it. So there was a study that was going to look at that, but that study was then canceled.
Okay, anything on the calcium channel blockers?
Calcium channel blockers have been used in many animal studies, but to my knowledge, they have not been used in any major human clinical trials beyond some pilot study that's unpublished that I don't know about.
Okay, about the study design, like since these kids, they have repeated dosing of this cisplatin, and like what is the reason for intratympanic that requires multiple, general anesthesia?
Yeah, well, that's always been the downfall of the transtympanic technique. And which is why the big clinical trials involve like IV administration of the sodium thiosulfate on a delayed administration type protocol. Now,
Do eardrops?
yes, so there are other possible delivery mechanisms. Like there's something called an oto wick, where it's like a tube that has a wick through it, and you place it so that the wick is towards the round window, and then you can apply drops and then do that. And there actually was a product out on the market like 15 years ago, but it's not available now anymore. It's been withdrawn. But that was a product that people looked at. And then right now, there are, for example, Autonomy as well as some other companies have these gel-based things that you can place into the middle ear that have extended delayed release that can delay the release over a period of as long as a week. And then the other exciting thing is something that Anil Lawani's group has. They developed these microarray needles, these nano needles that are inside a device, and you place it on top of the round window, and it can just administer through these nano needles over a long period of time, various drugs. But the reason why these weren't considered in this new COG proposal is because it was felt that if you tried to include any additional device on top of this, it would kind of complicate IRBs. And so they were more interested in just doing transtympanic, which is kind of a well-studied protocol that's been done for other treatments and, with success. And then and the cancer protocols that they're thinking about using are on cancer protocols where like a child receives 4 total cycles, 4 single doses of cisplatin. So they would only need to have 4 of these things. And these kids often go under brief anesthesias for things like PICC line placement, um, uh, lumbar punctures, bone marrow biopsies. So having like a brief 5 to 10 minute mask inhalation anesthesia for this doesn't seem to perturb the oncologist that much.
Any other questions? I see you, Tony. You always have questions.
Yeah, I guess I'm wondering what the half-life is for the drug, do you think? I mean, how for the when
Or
you
you ask
compare,
about sodium thiosulfate?
yeah, I guess the comparison between the two and how long you think, like, can you really keep it there long enough with a transtympanic injection to prevent the cisplatin from having
Yeah. So the
how long
data,
is the cisplatin going to be in the ear?
yeah, the data on that, we do have data on that in animal models, but honestly, I don't think there's really great data on that in humans. One of the issues that's always been proposed, that's been kind of raised with transtympanic injection in humans is that there's actually a fair degree of variability in middle ear clearance in humans. Some humans clear their middle ears really, really efficiently and really fast, and others don't. And what's placed in the middle ear stays in there forever. So those are definitely going to be issues. But I don't know that there's while there's good data on the persistence of this in animal models, the data in humans isn't quite so clear.
I have a quick question. Kate, what do you think about Lisa Cunningham's work showing that atorvastatin is associated with reduced cisplatin-induced hearing loss? And she found this in people, and the study was motivated after she showed in a mouse model that a related statin protected against cisplatin ototoxicity in mice. Because that can be taken orally. There are certainly kids who are on statins, especially those who have genetic types of hyperlipidemias.
Yeah, I think that's that definitely is a promising area, although for some inexplicable reason, that work hasn't been really glommed onto by the oncologists. And it's primarily pediatric oncologists that are involved with this, because adult oncologists, it doesn't seem to be as high an issue in adult oncology. The effects of that hearing loss on adults doesn't seem to be as great as it is on children, and also the incidence happens a lot less in adults than children. So this all kind of falls in more into the arena of pediatric oncology. And one of the things I discovered really early on when I was doing work in this area is that really, if you're considering work in this area, you have to kind of team up with the pediatric oncology societies. And like 99% of all children that are receiving cancer therapy in the United States are all on protocol. And as opposed to adults, the rate in adults is probably less than 10%. But if you're a child It's like 99.9% of the time you're on a protocol, and it's usually a protocol that's overseen by the children's oncology group. And so, you know, I don't know why the statins hasn't been like picked up by any of the oncologists as wanting to champion it and include it in their studies. And so I think it hasn't really been investigated.
Interesting. A related question. Again, her work showing that at least in mouse models, sound preconditioning can inhibit ototoxic hearing loss. That would certainly be very simple to administer to children in a clinical trial. In fact, everybody wears something in their ears these days. It could eliminate a trip to the OR or even to clinic. And they could even be testing their hearing using Mimi apps and UHear apps. So I'm just curious what your thinking is, how to simplify future clinical trials.
Yeah, I mean, that would actually be a pretty simple thing to give children. You just put a headphones on them and while they're receiving their cisplatin, that's way easier than any of these other therapies. It's interesting because that was kind of my first research project as a resident at the University of Washington, was sound preconditioning to inhibit noise-induced hearing loss. I did all these experiments where I blasted guinea pigs with noise and preconditioned noise and then examined their noise. Those are all my first experiments. So I'm not surprised that it could also potentially, it was very effective to decrease noise-induced hearing loss. It wouldn't be totally surprising to me that it would have some effect on decreasing other type of ototoxic hearing loss as well, because a lot of the metabolic effects are similar. So, that would be a potential area as well. I hadn't thought about that. And maybe I should give a talk to the pediatric oncologist suggesting this, because this is way easier than a lot of these other therapies. And certainly you wouldn't be worried about sound preconditioning inhibiting the cancer efficacy of your treatment.
Exactly.
It looks like the atorvastatin studies just actively enrolling patients now prospectively.
Oh, good.
So maybe the jury.
Is this in the pediatric arena?
This is an NIDD, so I don't think it's pediatric.
Ah, I see.
Yeah.
No,
18
that's probably why I don't know about it, because I actually have focused my research kind of on the pediatric side, and I have tried to keep up with some stuff on the adult side, but I haven't really looked at it, and so that's probably why I don't know about it.
Any other questions? Well, if not, we can have dinner early. Thank you so much, Kay, for the wonderful talk. I learned a lot tonight. Thank you.